Hello, everyone. Thank you for coming. I'm Jack, and thank you for joining us again on our lectures that we host for the Bridge to AI Consortium. We're pleased to continue the Bridge to AI Training, Recruitment, and Mentoring Working Group lecture series from 2025 to 2026 as part of our novel AI technology module. Today's lecture is titled Identifying Heterogeneous Treatment Effects Using Machine Learning for Future Precision Medicine and Public Health. This session explores an important frontier in biomedical AI, how we move beyond average treatment effects to understand how interventions impact individuals differently across populations. As healthcare data becomes increasingly high-dimensional and diverse, machine learning approaches are playing a critical role in uncovering these nuanced patterns. So we're excited to host today's speaker. It is our pleasure to welcome Dr. Kosuke Inoue, professor in the Department of Social Epidemiology at the Graduate School of Medicine at Kyoto University. Dr. Inoue is a physician epidemiologist whose work focuses on cardiovascular and clinical epidemiology with expertise in causal inference and statistical modeling. Formerly trained as an endocrinologist, he later earned his PhD in epidemiology from the UCLA Field School of Public Health. His research integrates causal inference with machine learning to better understand treatment effects and population health outcomes. Dr. Inoue brings a highly interdisciplinary background, combining formal training in endocrinology with advanced expertise in causal inference and statistical modeling. His work integrates causal inference methodologies with machine learning techniques to analyze complex data sets, including large-scale cohort studies and clinical trials. A central theme of his research is the identification of heterogeneous treatment effects, understanding how and why treatment responses vary across individuals and populations. By applying machine learning approaches to both randomized and observational data, his work continues to more precise to be more precise um, and evidence-based approaches in medicine and public health. Dr. Inoue has an extensive and impactful publication record as well, with over 160 peer-reviewed papers, including a substantial number as his first or senior author, and his contributions have been recognized through numerous prestigious awards, including the Young Scientist Award from Japan's Ministry of Education, Culture, Sports, Science, and Technology, and recognition from MIT Technology Review's Innovators Under 35 Japan. His work exemplifies the integration of epidemiology, causal reasoning, and data science to advance precision medicine, and we're honored to have him with us today. Before we begin, let's briefly review the learning objectives for today's lecture. First, we'll examine why assessing treatment effect heterogeneity is essential for understanding mechanisms behind average treatment effects and for identifying subgroups that may benefit more or less from a given intervention. Second, we'll explore how modern machine learning methods such as causal forests and meta-learners can be used to evaluate these heterogeneous effects in complex data sets. Finally, we'll discuss the high benefit approach, a strategy focused on identifying individuals most likely to benefit from treatment with implications for more efficient resource allocation and reducing health disparities in precision medicine and public health. With that, I'll turn it over to Dr. Inoue to begin today's lecture.
All right. Thank you very much for a very generous introduction, Jack. And also thank you very much for giving me this great opportunity, particularly Dr. Watson and Dr. Peng. I'm honored to present my research today. So let me share the screen. Okay. Can I see the screen?
Yep, can see it clearly. Thank you very much.
All right. Thank you. And again, I'm Kosuke Inoue from the Kyoto University. and I did PhD at UCLA, and I came back to Japan in 2021. So since 2021, I'm doing a faculty at Kyoto University. And today I want to talk about heterogeneous treatment effects, particularly using machine learning. And because Jack kind of introduced myself, I would skip this slide, but after training of internal medicine and endocrinologist, I went to UCLA in 2017, and in 4 years, I got PhD and came back to Japan, and then doing assistant professor, associate professor, and now group professor at the Kyoto University. And also doing an associate editor in International Journal of Epidemiology and also European Journal of Epidemiology. And this is my research roadmap. So as a clinician epidemiologist, I always try to bridge the gap between clinicians, epidemiologists, and basic scientists. And then my final goal is create robust evidence towards best clinical practice and patient care. And to do that, my tool is causal modeling and machine learning. And then I have three main projects. One is identifying mechanism. And when I say mechanism, it's not basic science research. It's more like an epidemiological identification of the mechanism. So let's say if adverse health childhood experience introduces cardiovascular events in later life, to what extent metabolic disorders mediates the pathway from that ACE to cardiovascular events. And the second project is identifying heterogeneity, which is the topic of today's talk. But instead of estimating, or in addition to estimating average treatment effect, why not estimating individual level treatment effect? And then the third project is very related to the second project. But if the treatment effect is heterogeneous, how can we generalize or transpose the results of the clinical trial or the study or our study to the population of interest? Because as you know, the population of interest is sometimes or often different from the study sample or trial samples. So today's talk focuses on this project too, identifying heterogeneity. And here's my key takeaway of today's talk. It is important to consider not only risk, but also benefit to achieve precision medicine and public health. So what does it mean? So here's the agenda of today's talk. First, I would introduce the concept of a high benefit approach as a future precision medicine and public health. And then I will explain two research. One is identifying heterogeneous treatment effects in clinical research. And the second is identifying heterogeneous treatment effects in health services research. And finally, ongoing and future projects, and then finish today's talk. So what is the high benefit approach? But before jumping into the high benefit approach, let me ask you a question. What kind of image do you have when you hear the name precision medicine or precision public health? A few years ago, I have this kind of image, and it was actually published in Nature Reviews Cardiology. But using like big data or omics data, whatever electric health record data, precisely estimates the risk of disease and then intervene patients or people at high risk. And that's a precision medicine, I thought. And actually, medicine has been prioritizing the treatment of patient with a high risk of adverse health outcomes, which we call high risk approach. And as you may know, we traditionally have two big approaches. One is a population approach, which is targeting everyone. But also the high risk approach is targeting individuals at a high risk. And very extremely speaking, for example, diagnosis is a high risk approach because we label people as a hypertension if they have a high blood pressure because they have a high risk of future cardiovascular events or death. And then start treatment for these people with hypertension. But this is defined by human, right? This is a high risk individuals. But the question is high risk really equal to high benefit? So in recent years, there has been a recent substantial advancement in the machine learning-based approach to estimate how treatment effects vary based on observable characteristics of individuals. So traditionally, in epidemiological studies, we estimate the population level treatment effect, which we call average treatment effect. But this population has a variety of people, right? Very colorful, red people, blue people, purple people. And then if we use machine learning, let's say the causal force model, and we can identify, well, red populations are very high beneficial from the treatment, but this blue population has a very low benefit from the treatment, or even harm from the treatment. And such an approach enables us to target individuals with high benefit. That leads to the high benefit approach. So the high benefit approach concept is quite simple. In addition to, or instead of focusing on people at high risk, why not focusing on the people at high benefit? So if we can estimate the treatment effect at individual levels, then we can directly target subgroups of high benefit, and then we can maximize the treatment effect from the, maximize the effect of the intervention. And we published this concept in International Journal of Epidemiology in 2023, and I will go more details later. So the first example is kind of proof of concept paper. How can we apply this high benefit approach in a clinical research? And here we use the sprint trial data, which is very famous and that you may know, the systemic blood pressure intervention trial. This is a large multi-center RCT, which showed 25 reduction in cardiovascular disease risk by intensive blood pressure control. And actually, it influenced the blood pressure guidelines and clinical practice a lot. And interestingly, in an original sprint trial data, subgroup analysis by each baseline characteristics showed no evidence of heterogeneity. So this is the figure from New England Journal of Medicine 2015. And then as you can see, there's no clear heterogeneous pattern by, for example, age, sex, race, and previous cardiovascular disease, or even systolic blood pressure. However, in a post hoc analysis we did, and actually I collaborated with Dr. Watterson for this research, subgroup analysis by race and living arrangement, we found the heterogeneity in the treatment effect by living arrangement among Black individuals. So among Black individuals, if we stratified it by living alone or living with others, then people living with others are likely to get much more benefit from intensive blood pressure control, while we did not find such a benefit among Black individuals living alone. So this research highlights the importance of social support or family support when we do the intensive care, particularly intensive blood pressure care. But this is not the primary topic of today's talk, but what I want to highlight is in a sprint trial, original trial, they did not find heterogeneity by each pre-specified variable. However, in a post-hoc analysis, we found heterogeneity by race and living arrangement. And of course, the evidence level is different. The original one is a pre-specified, subgroup analysis, but our research is post-hoc analysis. So the evidence level is different, but the key part of these results are in the same data set. We did not find the heterogeneity by a single variable, while we found the heterogeneity by two variables, if we use the two variables. So there is something here. And also, as a clinician, from a clinical perspective, of course, the effect of intensive blood pressure should vary across individuals. Like some patients are responsive to that intensive blood pressure control, while others do not. However, at this stage, no evidence existed about heterogeneity across individuals, taking account multifactorial characteristics. So the aim of this study is identifying demographic characteristics among those who get benefit from intensive blood pressure control, and then propose a new treatment strategy called high benefit approach by estimating individualized treatment effect. And because Sprint only included people without diabetes, we also merged data with Code BP, which is also conducted in NIH, and included people with diabetes. And eventually, we included 10,000 people who was able to be followed up for 3 years. And then we use the causal forest algorithm, which is a machine learning algorithm that using an ensemble of trees optimized to detect heterogeneous treatment effect across individual levels. So again, instead of estimating treatment effect on average, we can estimate the treatment effect for individual levels by using this machine learning. And how does it work? Well, first of all, the target treat effect of interest is different. In a usual analysis, we estimate the average treatment effect, which can be written this way. And this is a kind of, we call the potential outcome framework or counterfactual notation. What happened if we intervene on everyone? This is a yx equal 1. And then what happened if we did not intervene on everyone? This is a yx equals 0. And the gap of this yx equal 1 and yx equal 0 is average treatment effect. So in a very simply speaking, what's the difference of the risk when we intervene on everyone and when we did not intervene on everyone? But of course, we cannot do that in a single word, right? Once we intervene on some people, we cannot do the option not to intervene on someone because they are already intervened. So that's a RCT comes, like in a randomized control trial, we create two groups, treatment group and control group, and they're randomly assigned, so they're balanced. And then they can be seen as a kind of similar population or even same population. And then what happened if we intervene in the treatment arm, and also what happened if we did not intervene on the control arm. So that's the average treatment effect work. And in a heterogeneous treatment effect concept, we estimate conditional average treatment effect, or we say individualized treatment effect. And the difference from the average treatment effect is we have a W here. Otherwise, it's the same. What happened if we intervene on everyone minus what happened if we did not intervene on everyone, given W equals W. And this W is the characteristics. So for example, this W only has one variable, and then let's say the age is over 60 years old, then that's the subgroup analysis. Among people who are older than 60 years old, what is the treatment effect? So that's a CATE, conditional average treatment effect. But because we are having the opportunity to use machine learning, we can include a lot of characteristics in this W. And then if we define this W with using multiple characteristics, we can precisely estimate the individuals because these individuals have a very unique characteristics. Let's say age over 60 years old and a BMI 30 over 30, and then systolic blood pressure between 120 to 130. Something like this conditions, and then we can specify, oh, this is a people, a very unique set of people who have the same characteristics, right? So for example, today's participants is 12 people, and then if we define by 3 variables or 4 variables, probably we can identify some specific person in this group. So that's how it works for CATE estimation. And in a causal forest algorithm, because we set forest, first of all, we create a tree, and which we call causal tree. And if you look at the upper right figure, this is clear. So, for example, what is your sex? And then if you're male, what is your age? And if you're older than 60 years old, well, male older than 60 years old, estimated risk difference, which is a treatment effect, is about 5 percentage points. But if you're female with BMI under 30, estimated risk difference is 0.5 percentage point, something like this. So this is a decision tree, and in a real causal force algorithm, because we include a lot of variables, this decision tree is much, much deeper, right? Not only for the sex, age, and BMI, we include a lot of variables and then very deep trees we can create. And because we are saying the forest, we actually build this kind of tree, thousands of trees. And using that thousands of trees, averaging the results, and then get the final estimate from this algorithm. And they have also other technical like estimation process called honest estimation or cross-fitting, but I will skip for the sake of time for today. And then once using the causal forest, and we can estimate the treatment effect at the individual level or at the individual level characteristics, and then we can apply the high benefit approach because we know who are likely to get benefit from the treatment. So then we can target those individuals, right? And here's the results from the sprint trial. We actually found the heterogeneity in the effect of intensive blood pressure control on cardiovascular outcomes. So how can we interpret this figure? Well, if you look at the left figure, this Q1, Q2, Q3, Q4, Q5 means the quintile of the treatment effect, conditional average treatment effect. So by using machine learning, we can estimate the treatment effect at individual level, conditional average treatment effect, and then we create the quintile of that case. So Q5 means the top 20% of people with highest conditional average treatment effect, so highest benefit from the treatment. And Q1 is a subgroup with lowest benefit. And then among this subgroup, we just run subgroup analysis. So what is the treatment effect among these populations? And you can see the slope from left to right, and they goes up, so which means evidence of heterogeneity. In other words, if there is no heterogeneity in the treatment effect, the shape of this figure should be flatter, right? Whatever the ranking is, whatever the ranking we make, then it should not vary. So from left to right, it should be flatter pattern. But if we find the increase pattern, particularly monotonic increase pattern from Q1 to Q5, then there's evidence of heterogeneity, we can say. But this is kind of a narrative explanation. So more statistically, we have several metrics we can use, and one major metric is best linear projection model. And if we use that best linear projection model, we get the coefficient of the mean forest prediction and also coefficient of the out-of-back predicted treatment effect. And by interpreting these values, we can say, well, the model is whether the model is calibrated or not, and also whether model capture the heterogeneous treatment effect or not. And these, like how we interpret and how we can apply is explained in a GRF package, which is a causal forest package, GitHub in R. So if you're interested in, I would strongly recommend going there. And before applying these methods, applying this code, please read that guidance from the GitHub. And once we get the causal forest model, we also have an option to see the variable importance, which is the right figure. And this variable importance shows, well, age, BMI, HDL, blood pressure are quite important variables. And again, living arrangements are important variables to the treatment effect of intensive blood pressure control. However, this interpretation needs to be cautioned because this variable importance metric from causal forest is calculated from the frequency. The frequency they appeared in the tree algorithm. So how many times they are spread? Like in the decision tree process, how many times age happens, age appears. And this is the number we calculate the variable importance. But as we can see, that frequency is not always matched with the real contribution to the heterogeneous treatment effect. So it's not clearly the one-to-one, the, how to say, it's not the only metric of saying the variable importance of heterogeneous treatment effect, but it's just one way to assess how important these variables are. And then, interestingly, in a sprint trial, we found no correlation between systolic blood pressure and treatment effect of intensive blood pressure control. So this figure, x-axis is a baseline systolic blood pressure, and the y-axis is the conditional average treatment effect, the treatment effect at individual levels. And each dot means each individual. So if we plot, because each individual has a blood pressure information, and also we calculated benefit for each individual, we can plot each individual in this way, and then we can assess the correlation between this risk, which is the baseline blood pressure, and the benefit, which is calculated from the causal force model. And then, as you can see, there is no clear pattern from this figure. And then our question is, well, what's the performance difference between high benefit approach and high risk approach? So let's say we intervene on individuals at a high risk, which is a blue box, like people in the blue box, and which is the people at a higher blood pressure, systemic blood pressure at baseline. And the performance, if we intervene on individuals in the red box, which is the people who has more than zero conditional average treatment effect, so who are expected to benefit from the intensive blood pressure control. What's the difference in the performance? So before assessing the performance, we assess the characteristics difference between this red box people and blue box people. And then high benefit groups, which is the red box people are more likely to be older, female, and less likely to have cardiovascular disease history. And then high benefit approach showed 5 times higher average treatment effect than high risk approach. So if you compare the final average treatment effect in the situation where we intervene on individuals at a higher blood pressure, high benefit approach where we intervene on individuals at a high benefit people showed 5 times lower number needed to treat, like 11 compared to 61. So this is 5 times difference. And as you may know, the number needed to treat is inverse of the average treatment effect. So of course, average treatment effect is 5 times higher in the high benefit approach compared to high risk approach. And in a real clinical practice, we don't decide the treatment decision not only by the we don't decide the treatment decision only by the systolic blood pressure at baseline. We also calculate the cardiovascular risk score and other information. And so we did several analysis using the different metrics of the risk, but still we showed about 5 times higher number needed to treat in the high risk approach compared to high benefit approach. So in theory, because we target individuals at a high benefit approach has a potential to maximize the effectiveness of interventions. I think this is clear. But also, I would say high benefit approach has a potential to reduce disparity under multiple treatment strategy. This does not always happen, but if we have a multiple treatment strategy, I see the potential to reduce disparity. What I mean is, let's say, think about the diabetes treatment, and then we have a lot of medications recently, like SGLT2, GLP-1, DPP-4. And then if we can calculate benefit of each drug for each patient, then we can provide the optimal treatment strategy for each patient. And this can be different, right? It can be GLP-1 for me, but it can be SGLT2 for Dr. Peng, right? Then clinicians provide the best treatment strategy for each patient. By doing that, even people with a vulnerable population, even the vulnerable population or people with, for example, low socioeconomic status, get the maximum benefit from the treatment, and then we have a potential to reduce the disparity. If we do not have such a multiple treatment strategy, we have to be very cautious because that means we do not have alternative treatment approach. And then if we just decide whether we should treat or not, and if low benefited people has a kind of vulnerable population or people at low socioeconomic status, then we have a chance to uh, increase the disparity, existing disparity. So in that scenario, we should be very cautious. But if you have alternative option or multiple treatment strategy, there's a potential to reduce the disparity. So in conclusion, using large clinical trial data, we found individuals with the highest risk of cardiovascular outcomes were not always the ones who benefited from the intensive blood pressure control, and our machine learning-based high benefit approach outperformed the high risk approach with a large treatment effect. And these findings indicate the high benefit approach has a potential to maximize the effectiveness of intensive blood pressure control in precision medicine era. So this was published in IJE in 2023. So if you're interested in, please read this paper. And then in the remaining 15 minutes, I will go to the next research in health services research. So the previous example is a really clinical research questions, but it can also be applied in a health policy standpoint or health services research. And the topic of this research is the effect of health insurance on health, which is a very huge topic in the US. And so far, they're having three major RCTs, which is a run health insurance experiment, organ health insurance experiment, and randomized taxpayer outreach by IRS. And here we use the organ health insurance experiment, which actually has a mental and physical health outcomes a year after the intervention. So what's the organ health insurance experiment? Well, this is not originally designed as a RCT. It was actually policy decisions. This study actually leveraged the random assignment of access to Medicaid insurance coverage in 2008 for low-income and uninsured adults in Oregon. And because this Oregon state used a lottery system to decide the eligibility of the Medicaid, Catherine Baker and her team used this lottery as a random assignment. And then they collected data after that assignment and then assessed the effect of Medicaid eligibility and also Medicaid enrollment on those outcomes. And they included a lot of physical measurements, including blood pressure and A1C, so we can use it as an effect of Medicaid on these biomarkers or physical examination markers. So what's the result of the organ health insurance experiment? This was published in New England Journal of Medicine in 2013, and as expected, healthcare utilization increased. So once people get the Medicaid, then they are more likely to use the healthcare. Hospitalization increased, outpatient care increased, prescription drug increased, emergency department visits increased. And the good news is financial hardship also decreased. And this is because they have now access to the care and they also have insurance for that healthcare access. Then they got the lower financial hardship. So this is good. But the more challenging interpretation of the organ health experiment is health. The probability that people reported themselves in good or excellent health is increased, and rates of depression substantially decreased. So this is very good. However, they did not find beneficial effects on blood pressure and A1C. But in any cardiovascular risk factors, they did not find the improvement of these markers after the Medicaid enrollment. So in summary, Oregon found improvement in access to care and outcomes, including depression, but found no evidence that Medicaid coverage improved physical health, including cardiovascular risk factors such as blood pressure. And we thought, well, it is possible that certain subgroups in Oregon population experience an improvement in cardiovascular risk factors, while the average treatment effect was diluted by other subgroups who did not benefit from Medicaid coverage. So the objectives are to investigate whether health insurance generated greater improvement in cardiovascular risk factors, such as blood pressure and A1C, and then identify characteristics of those with high predicted benefits. The Oregon experiment included 12,000 participants. And then again, intervention was the lottery, and exposure was the health insurance, which is a Medicaid coverage. And outcome we use were depressive symptoms, systolic blood pressure, and A1C. And they corrected a lot of baseline characteristics here. And technically, we use the instrumental variable methods because randomization can work as an instrumental variable, and then we can estimate the effect of Medicaid coverage itself uh, without bias, without particular bias from unmeasured confounders. And in this research, we also use the causal force algorithm, but more technically, we use the causal force algorithm with IV, with instrumental variable methods. So if you're interested in, please read this kind of, they published a paper about IV forest, and also these equations hopefully make sense. But using the IV and conditional average treatment effect estimation, we can estimate what happened if we intervene like Medicaid enrollment at individual levels. And here are the results. So for the first of all, depression, they found the benefit for depression on average, but also we found the heterogeneous effects of this Medicaid coverage on depression. Interestingly, the conditional average treatment effect distribution showed bimodal distribution. So some populations are received high benefit, but others had a low benefit, even though the second low benefit is still benefit. So again, the message is, well, Medicaid enrollment improves the depressive symptoms, but that improvement magnitude varies across individuals. And when we assess the details of this heterogeneous treatment effect, those who are expected to have a large reduction in depression risk by Medicaid coverage were older and had more physical or mental health conditions at baseline. So in this figure, x-axis is age and y-axis is a treatment effect. And if you see this figure, you can see the rapid increase after 35 years old or 40 years old, which means like effect of the Medicaid enrollment on the depression really increases after 40 years old. But even people with 20 years older, they get the benefit, right? The magnitude of the benefit is still smaller in a younger population, but in the older population, they have a verge. And very interestingly, we also found the heterogeneity in the effect of Medicaid coverage on blood pressure. So again, this is the Q1 to Q5 calibration plot. The x-axis is a ranking of the estimated conditional average treatment effect. And then you can see the monotonic increase from left to right. And then, which means, well, some people get benefit while others do not from the Medicaid enrollment in terms of the blood pressure. And when we assess the average treatment effect, the benefit, when we, in the situation of the high benefit approach, which is the targeting individuals at high benefit, then high benefit groups showed the substantial reduction and particularly clinically meaningful reduction in systolic blood pressure by Medicaid coverage compared to the overall population. So in the high benefit group, they are actually about 70% of the total population. And then estimated reduction in systolic blood pressure was 3. And 3 reduction in systolic blood pressure is clinically meaningful from the public health intervention perspective because they only provided Medicaid coverage, right? This is a public health intervention. This is not a medication. But then, even then, that situation, systolic blood pressure reduction in a 3 means something. And the final interesting part of these results are the high benefit group tend to have no or low prior healthcare charges at a baseline. And this makes sense because people who did not have enough access to the care at baseline got a higher benefit from the Medicaid coverage because they got the insurance and they got the access to the care. They can see the now they can see the doctors, and then they show the improvement in blood pressure. While people already had access to the care, they did not get the benefit from the Medicaid coverage, at least in this data. And of course, other reasons are there. Like, for example, this systolic blood pressure was measured 1 year after the Medicaid coverage. The 1 year follow-up might be too short to see the overall effect, but still, at least from this heterogeneous treatment effect estimation, we see some mechanism why the overall results are null and what kind of people actually have a potential to get the benefit from the treatment. I see Dr. Watterson raises a hand. Do you have any questions here?
Sorry, that was inadvertent.
Okay, thank you. All right, and so were there no detectable effects of Medicaid coverage on average? Certain individuals showed significant improvements in systolic blood pressure from Medicaid coverage, and these individuals were likely to have no or low prior healthcare charges at a baseline. And we can consider some potential mechanisms like improved access to care and reduced out-of-pocket healthcare expenses, and also reduce stress. All of these mechanisms can introduce improvement of physical health or better, lifestyles, and then better adherence to the prescribed treatment. So in the second period, using again machine learning causal force model, we found that the effect of Medicaid coverage on mental health and cardiovascular risk factors are heterogeneous. And then Medicaid coverage improved cardiovascular risk factors, particularly blood pressure, for certain identifiable subgroups. And these subgroups were the people who lacked access to the healthcare at the baseline. So these findings highlight the importance of investigating heterogeneous treatment effect estimation when assessing the impact of intervention, such as health insurance coverage. So this concept can be applied not only in the clinical practice or drug intervention, but also more broad healthcare intervention or health policy interventions. And this was published in BMJ about a year ago. So if you're interested in, please read this paper as well. All right, so these are the main papers I worked on, this heterogeneous treatment effect estimations, and the proof of concept paper was the first research I showed, and the HDE in randomized control trial is the second paper, second research I showed. But of course, we are interested in not only in the randomized control trial, but also observational studies, right? So we also assess the heterogeneous treatment effect or heterogeneity in the association in the observational study setting. And this circulation paper is one example. And this is the main preparation work with Dr. Watterson. And we did assess the heterogeneity in the association between the CAC and cardiovascular events using MESA. And currently there are a lot of machine learning algorithms, including causal force. Causal force is one of the most popular approach. That's why I explained today, but other method runners called R runner, DR runner, X runner are there. So we summarized these algorithms and explained what the pros and cons of each algorithm in this JSE paper. And when we say the precision medicine, we can also not avoid the genetic statistics. So in this research, we assessed whether benefit correlates with the genetic risk score, which is polygenic risk score. And our answer to that question is, well, it really depends. Like for some situations, PRS correlates with the benefit. So probably people at a high genetic risk score makes sense. But this does not happen always. Like for some situations, they do not have a correlation, like obesity to cardiovascular outcome, cardiovascular disease, coronary artery disease, for example. We did not see the correlation. Then in such a scenario, estimating the benefit is also important in addition to think about genetic risk, because targeting people at a high PRS or high genetic risk score may not work in this setting. So what's the ongoing and future projects? Well, there are a lot of works we have to do. And in terms of the methodology perspective and also application perspective, but mainly I have three projects. One is improve interpretability these HD assessment using causal machine learning. Like explainable AI is a kind of buzzword, but this is very important. If we assess the heterogeneity, well, even the computer can know there is a heterogeneity. We need to explain it, and also we need to interpret it. And finally, to implement these results to the society or clinical practice, that interpretation or understanding of what happens is really important and a very key part of this analysis. And the second one is a target trial emulation to assess HTE. The target trial emulation is a kind of causal inference framework to investigate the effect of the treatment in an observational setting. And this is getting much more popular in the recent 5 years. So we currently combine this target trial emulation framework and HTE assessment and how we can advance the evidence using observational data in addition to RCT. But of course, even if you use a target trial emulation or whatever the methods in the observational data, we have a lot of bias. We cannot eliminate the bias. So in a methodological perspective, we are quantifying the bias quantification when considering the HTE and high benefit approach. So those are the key three projects. And in the near future, I also aim to do the randomized control trial to assess the usefulness of the high benefit approach, because today's, for example, research is our post hoc analysis and the secondary analysis of the RCT. But to actually implement this high benefit approach and convince everyone whether high benefit approach works or not, I think at least one RCT is needed for this concept. This can be the future project. And in terms of interpretability, this is one example published in EJE. We propose a pragmatic subgroup discovery framework for heterogeneous treatment effect. So instead of finishing with the Kate estimation, we identify the subgroups based on that estimated Kate. And this is actually based on the concept of machine learning prediction model approach. Like in a PNAS paper in 2019, they proposed three metrics of interpretability: predictive accuracy, descriptive accuracy, and relevancy. So in line with this concept, we apply that in the heterogeneous treatment effect estimation and propose how we can improve these three metrics of interpretability when we use machine learning in this field. And this is an example using the look-ahead trial. And we can, for example, get these kind of explainable groups in the final output, like people with high history of cardiovascular disease and CAPG, then they may get a large benefit from the lifestyle intervention, intensive lifestyle intervention, while people without history of CVD and under 60 years old, they may not get the benefit from treatment. This kind of explanation is much more interpretable to the society compared to what I say, well, the algorithm says these people will benefit, but the others do not. So by doing this research, my aim is to popularize the high benefit approach and provides evidence about high benefit approach as a third approach in future precision medicine and public health. And of course, this does not decrease the barrier of population approach and high risk approach. If it works, I would definitely prefer the population approach and high risk approach. But if this approach does not work well, high benefit approach, I think, can be the alternative option with the future precision medicine. With that, I will end my presentation and would like to take any questions. Thank you very much for listening.
Thank you, Dr. Kosuke. This is amazing. I learned so much. It's very insightful. We have a tradition where we ask your help to address questions from the audience. I'm going to give it to Dr. Carol Watson first. Carol, you're muted,
Oh,
dear.
sorry, sorry. Kosuke, that was phenomenal. And every time I hear your work, I am just more and more impressed. I really, really was interested in your slide on the high um, benefit approach that could reduce disparities. I really like that. And it makes a lot of sense. Targeting those at highest risk could produce the most benefits. How do we deal with the fact that many of the risk estimates are less accurate in certain populations, especially the underrepresented populations? How sensitive are these estimates to the heterogeneity and the lack of precision in the risks?
Yeah, thank you very much for the great question. And this is a challenge in this field and a potential for future research. But I would say estimating the benefit is much more harder than the estimating the risk. So if the situation, the risk is less accurate, estimating benefit can also be a less accurate for that situation. And the reason is if we estimate the risk, then we need information of the baseline, like characteristics, and what happened in the, for example, 10 years. But if we estimate the benefit, we need a treatment arm and control arm. So theoretically or ideally, we need RCT data for any questions. But of course, we do not. In that situation, we sometimes use an observational study, which can be confounded or which can suffer from the bias. And even RCT, the population can be different, right? The sample might be different from our population of interest. So from these reasons, estimating benefit is currently less accurate, tended to be less accurate compared to the risk. So that's the challenges for the next generation, like we needed to do in the next 10 years.
That's fantastic. Thank you.
Thank you.
Thank you both. So we have a few more questions in the audience question and answer chat. If it's okay, I will read these to you. And the first question, Kusuki asked, how do you balance your model complexity with interoperability when clinicians need to trust and act on heterogeneous treatment benefit effect estimates?
Yeah, this is also a very good question. And this relates to the interpretability aspects which I showed in the last slides. But we still have a space to improve the science communication, how we provide the results of HCS estimation to the clinician or society. The one idea I have is in the near future, we can implement the algorithm itself, but that algorithm should not depend on a variety of measurements. I will say if it depends on the measurements we use in a clinical practice, which is very useful to clinicians. Let's say if you use some variables to calculate the prevent risk score, right? And if you use the same variable in a prevent risk score and then calculate the benefit, that is quite feasible and understandable, acceptable to the clinical practice. So that's the one way I would think of. The other way is, as I showed in the last slides, very, how to say, decrease the dimension of the results, and then provide such a very rough estimates from a lower dimensional characteristics, such as like people with history of cardiovascular disease and a history of CAPG or something like this.
Very interesting. And what you just mentioned, Kasuki, regarding algorithms-based clinical practice, and that's really one aspect where we see tremendous innovation and revolutionizing the field, isn't it? Because while we transition from the classical communication and observation-based therapy, the next phase was very much the chemistry and imaging technology based therapy, where you get blood test of all markers, where you actually get images of all problems that we have through CT scans. And now, as
Absolutely.
you said, we're actually are moving into the precision medicine direction where we compute and model potential problems and then using that to guide our therapy. Very, very interesting. And I have two more questions for you. The next one is, how do you translate heterogeneous treatment effect estimates into actionable clinical decisions without the issue of overfitting or potentially introducing bias? I know you touched upon that. Yeah. Here's your PowerPoint
Thank you
slide.
for that question
Uh-huh.
as well. I skipped actually this overfitting issues, and they're also a very good good question and important point of the machine learning algorithm. But in a causal force algorithm, we try to avoid the overfitting using the cross-fitting approach. And in shortly speaking, this cross-fitting works because we build the causal force model using the data without the individuals of interest. So let's say if I want to estimate the conditional average treatment effect for a specific sample in fold K in this cross-fitting figure, and then we build the causal force model using data without fold K. And we repeat this process for each fold. And by doing that, algorithm doesn't depend on the individuals of interest to estimate the K for their K itself. So that's a very brief explanation of cross-fitting, but if you're interested in, I would recommend to go into the paper, which might help you to understand better.
Thank you. I think that's a great answer itself. I do have one that I'm going to switch the order somewhat. One question it asks you, what would be an ideal sample size? Because I think that's a question frequently asked. So in your experience, how does sample size matter? Is there such a thing as a minimum sample size, or really it's specific cohort dependent and
Yes.
variables dependent?
Thank you. Yeah, this is also a huge topic, and I think there are several, grant projects going on that phase, but we do not know the answer for that question. Like we do not have a strategy to calculate the sample size like we do in, for example, AT estimation in RCT. So we don't
Hmm.
know, but from my experience, absolutely it depends on the magnitude of heterogeneity. If the treatment effect really heterogeneous, we may not need a large sample size. But if that heterogeneity is very small, like tiny space, then we need a large sample size to detect that heterogeneity. So it depends on the magnitude and also depends on the covariate set. Like let's say if you only have a 3 covariates, then you may need a lot of sample size to identify heterogeneity by these 3 variables. But if you have 100 variables, then probably you need less to identify heterogeneity for that 100 variables. So it also depends on the covariates number. And very roughly speaking, for example, can you do this analysis using 100 samples? Probably not. It's really hard to do the 100 samples heterogeneous treatment effect estimation. But if you have more than 1,000, it's feasible. So that's a rough estimate.
That is the sample size question is actually being asked repeatedly in many conferences that I have attended. And the most interesting thing is, you guys probably know I take computer science classes online that's taught by Stanford Computer Science Department. And so I asked that question, I posed that question to the entire class. And apparently, at this moment, unlike the statistic analysis we've all done for years, where we have a way to compute the precise sample size required to achieve certain statistics significance for machine learning models, there hasn't been a consent how to come up with a minimum required sample size. But let's all pay attention to what's going on. What I was told at the Stanford class is this is actually a question many PhD students are working on the theoretical part, but how do that translate into what we do using machine learning? I think that's slightly different.
It's good to
I,
know. Thank you.
yeah,
Thank
I
you for
do have the
sharing.
last question for you. And one audience asked, how do you ensure that identifying high benefit subgroups wouldn't inadvertently reinforce existing healthcare disparities or bias? That's a
Yeah.
tricky one.
Yeah,
Very important one.
very important. Very important one. And again, we have to be very cautious, particularly if you do not have, or if we do not have the alternative option, like whether we intervene or not situation, then we should be very cautious because if that people are at low benefit, uh, like the kind of social disparity, then we should not go for it because that high benefit approach would increase existing healthcare disparities. And when we implement the interventions, we do not we care not only the treatment effect itself, but also like disparity and other aspects, right? So in that scenario, if you do not have the alternative option, then we should be very cautious. And how we cautious is details. Look at the details of the distribution and who are the characteristics of high benefited people. And if we implement this, what is the potential, results among the people at, for example, high SES and among people at low SES, and compare these results. Does it matter or it doesn't matter? By doing that, we can have more transparent and fair discussion. If we have alternative option, then we can go for the alternative option to that population. That could solve a problem.
Thank you so much again, Kosuke. Back to you, Jack.
Thank you, Dr. Inoue. That was a fantastic presentation and very, very thought-provoking Q&A session. Um, I'm sure the Bridge to AI Consortium is going to benefit enormously from this lecture, not just today, but also online. We will be posting the lecture online for people to use as a great resource to learn more about machine learning. And then just a quick little plug, on April 30th will be the last lecture for this series. It is going to be given by Dr. Kevin Liu on emerging applications of transformer-based language models to comparative and evolutionary genomics. That'll be on April 30th. So please stay tuned. Thank you very much for tuning in.